In colon cancer, we started off with stool tests. We now have fancy stool tests, so fancy they have a golf tournament now. We now just recently came out with a blood test. Guardant came out with an approved blood test for screening. And so one way I'm thinking about this is you now have no excuse to not be screened for colon cancer. But do remember that the stool tests and the blood tests are not one every 10 years like the colonoscopy is, but it's much more frequent. The plain stool test is annual, the fancy stool test every 3 years, the blood test every 3 years, and of course they cost some money. But do these actually pick up half of my clinic? Half of my clinic is now 20, 30, and 40 years of age. And we have this explosion of young people with colorectal cancer, and we have no idea why. It's not what the American Cancer Society says. It's not a bunch of fat, Cheeto-eating, TV-watching people. It is very, very fit young people, and almost all of them, about 90% of them, are in fact rectus sigmoid cancers. Instead of the sort of normal 60-40 spray of colon cancer around the GI tract, they're almost all right here. And we've got to figure out what the heck is going on in that space. So if we're going to cure GI cancers, colon cancer in specific, we got some work to do. We have some of our cancers which are quite responsive to immunotherapy, but many and most are not. We have signaling pathways, but they're redundant and they're upregulated, and not one drug is going. Our drivers are not powerful drivers, where if I just find the right wire and I cut it, I solve the problem. That's not the way colon cancer behaves. There are multiple pathways that have to be shut down. We are learning more and more how to deal with oligometastatic disease, the only cancer where we actually resect it for cure, metastatic disease, resecting for cure. And we're going to talk about some new ASCO data around liver transplant. We're going to have to do, and I know I'm in AI territory, everybody here loves AI, and so we're going to have to figure out how to make sense of all of those terabytes of data to help predict who should get which therapy. The clinical trial process, I also know I'm in CRO land, is badly broken. And we need to accelerate and expedite how we are doing clinical research today, somehow dropping the price of this. The Inflation Reduction Act, I don't know if this is on your radar, but it's on every drug developer's radar, because now we're going to negotiate price for drugs in the United States, and now that $1 billion of reinvestment going back into clinical research is likely to get smaller. And so there's going to be less of a pie to distribute around in order to do more drug development. So we're going to have to figure out what we're going to do there. But of course, by Tuesday, we're all going to be at war anyway, so it really probably doesn't matter. We have some windows of opportunity to cure colorectal cancer. The breast cancer world led the way with this concept of neoadjuvant chemotherapy and treatments in general through the I-SPY program and others, transforming how we take care of breast cancer. We have not had a change in the world of adjuvant therapy for 20 years in colorectal cancer. I'm giving the same drugs I've been giving since I had hair, okay? And so this is something that we've got to come back and fix. But we also have this perioperative setting where there are no drugs actually FDA approved for the perioperative metastatectomy setting, and this new emerging ctDNA window of no evidence of disease but molecularly positive minimal residual disease is a new area, I think, for curing patients. So what do we do today? If you're stage 1, we pat you on the back and say, you're almost certainly cured. Not for sure, but you're almost certainly cured. Go away and don't bother me anymore. Stage 3, half the patients are cured by surgery already. The other half we know are in trouble. We don't know which half is which. We give all of them chemotherapy. We give chemotherapy to 100 people knowing that we're only going to help about 20, 25 of the 100 that we're giving treatment to. Does oxaliplatin work in everybody? No, probably not. There's no data to say it works in the over 70, no matter how fit you are. And there's no data that it really says it helps in stage 2 disease. Should we apply this to rectal, for example? But if you notice, none of this represents RAS, BRAF, sidedness, MSI. None of that's represented in our current recommendations in the adjuvant space. And I can't tell you a cancer where that's not already part of the day-to-day lexicon of how they give adjuvant therapy. We need to get there for here. So let's talk about duration of adjuvant therapy. I've been doing this for 31 years now. So when my intern year, though, a guy named Norm Warmark said we should be giving adjuvant 5FU for 18 months. We just kept giving it because we didn't know any better, and you just kept giving it. By the time my fellowship came around, we were now giving a sheep anti-helminthic called levamisole to patients, because that seemed like that was immune therapy, by the way, we thought. We then did a study that looked at 6 months versus 12 months, and 6 was just as good as 12, so that's where that comes from. There were some people starting to look at prolonged infusion 5FU, showing that 24 weeks was about the same as 36 weeks. So every time we made it shorter, we didn't lose any ground. And then finally, once I became a professor, 3 months of prolonged infusion was just the same as 6 months of bolus. But did we believe that? No, we still stuck with 6 months because that seemed like the right amount of time. And then came oxaliplatin. Anybody ever given this drug? All right. You can't touch anything cold for like, a week, that kind of thing. But we love this drug. And here's the paper that came out in 2004. Where were you in 2004? So there's my family in 2004. It's before my wife had breast cancer. There's Charlie and Emma. And there are my kids now. So no change in adjuvant therapy for all of that window. Okay, we're giving the same drugs to all the people and no progress at all in this space. But let's look at the data here from oxaliplatin. We're in love with oxaliplatin, right? We think it's an essential component. Here's the Mosaic clinical trial. Anybody need glasses to see the delta there? So this is 5FU ox versus just 5FU. And you can see in the top there that little sliver of a delta between the blue and the yellow curves up top there. So it's a little amount, not double, it's a little bump over at the top. And in bottom, those blue curves, the blue and yellow up top are stage 2, no delta whatsoever. And these are in good performance status stage 2 patients, right? And in stage 3, you see a little bit. So it's about 5%, optimistically 3 to 5% bump on top of what we get with 5FU. But neurotox is bad, right? I mean, we know we're having to manage it. So we finally did this study. This study is huge, 12,000 patients all around the world, 3 months versus 6 months. And it's all because of the oxaliplatin. And I think everybody in the room knows the results. It was a randomized study. The fundamentals of the 6 clinical trials that were done around the world was they had to compare 3 months to 6 months, and then they were all pooled to be more than 12,000 patients. Because why does it have to be so big? We can't leave anyone behind. We have to show that it's the same. Because if we stop at 3 months and the patient's cancer comes back, we'll feel like it's our fault, right? If we'd only given you 6 months, you would not have had your cancer recur. So we feel like we're obligated to give. So to back it down to 3, we have to be really sure that we're not leaving anybody behind. You with me? So it has to be huge so that we can avoid regret, that it wasn't our fault that the patient's cancer recurred. And so here's the results. What do you think? So look high. Look in the little box there, 74.6, 75. So at worst, here you're leaving one person behind. You with me? You see the math there? One person delta for 3 versus 6 months. This is the overall numbers. But then we start slicing and dicing, of course, and there's the T3N1s, no delta, okay, none, right? And then the higher risk group, there's a little bit more. There's 2, maybe 1.5 people, right, in the higher risk. So you're giving everybody neurotoxicity to pick up that one person, that one additional person. And I think our patients aren't aware of this because they don't want to blow it either. We don't like oral 5FU here in the United States, the great United States of America. We like IV 5FU, but look, really, oral's probably better drug if you give it right. So there's that. And then here's the final paper. If you want to tell your patients, yeah, 3 is about the same as 6, there you go. Can't slide much between there. You can see the overall up at the top, 5-year overall survival, all right? So in my book, 3 is the standard of care, and you got to convince me to give more, all right? Why would I give more? And we'll talk about maybe a situation where you might. Then comes along this breakthrough. Now, this group, led by Andrea Sursek and others, really said immunotherapy is going to have to work in GI cancers and colorectal cancer, and let's pick the microsatellite unstable Lynch patients to look at that. And the original studies, despite all the investment in immunotherapy that was going on around the country and around the world at this point, these were investigator-initiated trials. These trials were led by philanthropy, not by the companies that sponsor these drugs, okay? And so, because they were convinced this was going to change the standard of care. And these are MSI-high positive rectal patients. It's usually good when a doctor is on the Today Show. Not always, but it's usually good news when they make the Today Show. So they're CNN and everything else. But the gang up in New York did this clinical trial. And it was basically, could we avoid surgery in rectal cancer? Sort of taking a lead from our breast cancer colleagues with their neoadjuvant therapies and their very high path CR rates, could we in fact avoid a surgery that none of these patients really wants because of the risk of ostomies, et cetera, right? So they gave MSI-high patients with rectal tumors immunotherapy and then watched them. And if they progressed or if there was still residual disease, they would give them radiation therapy and do the standard surgery, et cetera, all right? You all know the results of this study? 18 for 18. 100% of patients, all their cancer went away. Okay, and these have been updated. This was the original publication. It's ongoing. That no one with a rectal cancer yet has not had a clinical complete response. It's a little lower, interestingly, in colon, believe it or not, so geography here matters. And if you have metastatic MSI high, this number drops to about 70%. So something happens as the tumor progresses from local to metastatic that the immune therapy in the MSI patient, that the immune therapy doesn't work as well. So we got to figure out what the heck's going on there. So let's look at rectal cancer. So we have to think of the colon now as at least 2 and probably 3 organs. It's not one organ. It's molecularly different and anatomically different. And rectal, of course, is where all these young people are having their cancers as well. So we need to really think about how we do things. So let's look at our goals. We want to cure the patient, 1. We want to poop out of the correct hole, 2, right? And we want to minimize overall toxicity. Because a lot of these young people are still, of course, hormonal, they're premenopausal, right, at this point. So we want to try and protect as much of that as we can. And so if you've ever dealt with patients with this problem, the laundry list of the problems they get is pretty big, right? Urgency, you can see all the different things that happen there after we're done with you. We're glad we cured you, but you now have to deal with this for the rest of your life. Okay, that's where we are with this. So, it's 3 different subsections, rectal cancer. Upper rectal probably could be treated like sigmoid tumors. Lower, we're trying to avoid surgery. Middle, we're trying to poop out of the right hole, and maybe can we avoid radiation long term, all right? So these are the different ways we are even thinking about rectal cancer by its different locations. So when I stepped in a long time ago, the standard was to give surgery first, then you chased it with chemoradiation. Why did we do that? Because at the time, we were doing bad surgery, all right? We didn't understand that there were true fascial planes that you could operate down and therefore not have local relapse, local soilage of the tumor. Because if the tumor had gone all the way through the bowel wall or if there were lymph nodes, that old chiseling it out surgery left to about a 12 to 15% local relapse rate. And so we radiated them. We cleaned them up. We cleaned up bad surgery, which was very effective, and then we cleaned up systemically. But this was the original way. The Sauer study comes along and says, well, wait, what if we do chemoradiation first? That might be a better idea. And this has been the standard for a long, long time. Now note, this did not improve overall survival. It improved local anastomotic rates and local recurrence rates. So those were good if you did it this way, but didn't improve overall survival. And then we started playing with this. We started saying, well, what if we just give everything first? Let's give the chemo first, and then maybe the chemoradiation, or maybe the other way. and then we'll do surgery as the last thing. And a lot of this did not come on the backs of randomized studies. It came with different centers deciding this is how we were going to do it, and other centers doing it differently. So now we have all sorts of plans out there. We have short course radiation and long course radiation. We have chemo first, radiation first. We have all sorts of different strategies that are out there. And believe it or not, on Wednesday afternoon tumor board, we kind of call an audible every time on this. We go, well, I'm going on vacation, so we'll do short course. Or let's do radiation first because we've already got them teed up, and then we'll do we just call whatever play we think makes the most sense. Not crazy, none of this harmful, but not organized either, and not really trying to drill down and answer questions about how best to manage it. Until this smart doc, Deb Schrag, just joined the Academy of Medicine, did the Prospect clinical trial, and lots of us participated in this, and it's pretty straightforward. Can I do without radiation? So you took mid-rectals, and they randomized between standard chemoradiation versus chemo only, pre-op. And then if you had a good response to the chemo, you went to surgery. You skipped the radiation. If you didn't have that good a response, you had defaulted to the chemoradiation and then surgery, right? And remember now we're doing good surgery. Everybody's getting good surgery everywhere around the country. And so look at the top. The results are way up at the top. See them up there? There's 2 lines up there. This is the local relapse rate of whether you did radiation or not. Can you see it? You see both lines up there? They're pretty tough to distinguish. There's 2 of them. Here's your overall survival with this strategy. All right, so a lot of people, the radiation benefit was unclear. So this is where we are now. We're still treating a lot of people with radiation when we've got this kind of data to support not doing it because we're unsure, we're unsettled about all of this. Should we apply the 3 months to rectal cancer? We a lot of times give 3 months before, and what the heck, give 3 months after? Do we need the 3 months after? I don't know, is this the same rules here versus the other cancers? Let's see, there we go. Does oxaliplatin, there's never been a study that actually shows oxaliplatin even adds that 3 to 5% in this disease, even though all of those studies, the Prospect included, used oxaliplatin in the preoperative setting. So we have a shifting sands here of how we manage rectal cancer and the like. But what about the rest of adjuvant disease? So what we really need is one of these, right? We need a Harry Potter sorting hat for me to know, after your stage 3 disease, are you cured? The 50% who are cured, you're in Gryffindor, right? Are you not cured, but 5FU will cure you? That would be Hufflepuff. You're not cured, but 5FU and oxaliplatin will cure you. It's Ravenclaw. That's only 5% of people going into Ravenclaw. And are you not cured and you're going to die? That's Slytherin, right? That's what I need. That's who they are. Every time I see a stage 3, I'm like, who are you? Which one of these are you? Because you're one of them, right? We've cured 75% of the people with stage 3 colon cancer already. What we don't know is the Slytherins, how to find them, how to treat them differently. And so we are getting new technology. The ctDNA has emerged. Breast cancer, lots of different cancers are now playing with it, right? And so here's some of the early Jeannie Tai out of Australia did this clinical trial using ctDNA. This is finding DNA from the patient's cancer in their blood after surgery. So there's still some cells around somewhere. And just so you have a sense, in order for ctDNA to be positive in your blood, a cell has to have died somewhere in the last 3 to 5 hours, because that's the half-life of circulating tumor DNA, right? So if it died 2 weeks ago, it won't be in your blood, right? If it's slow and not dying, it won't show up, right? So there's not a perfect test, but if you're positive, you are positive. There is no little bit pregnant here either. And finally, we did some studies. And this is the Circulate clinical trial looking at if you were negative or you were positive. So if you're negative, that's that top red line up there, you're in the 90% range. And you better believe patients know when they're negative that that's where they are on the curve. Not perfect, not absolute, but pretty good. You're probably not in Slytherin, okay? All right, so the ones that are in trouble are the ones that are positive. Does chemo help if you're negative? That's the sort of, probably not. The green line at the top is you were positive and chemo flipped it to negative. So all of a sudden, those are the Hufflepuffs, right, and the Ravenclaws. That's who that is, right, because they've been converted to being cured. Does chemo help? If you're negative, should you just give it because you don't want to regret when the cancer comes back that it's your fault? That study says no, you shouldn't. Shouldn't just give it anyway, but we do. We do it a lot. Okay, I'm one of them. So now we're doing some prospective studies looking at if you're positive, could we be guided in your treatment based on being positive or negative. So this is the new wave that I think is going to have an impact on this space. And there's the update of those data so far of the dynamic study. And one group I want to point out is the T4N0s. These are transmural penetration but no lymph nodes. And to me, this is the peritoneal cancers. They're not showing up very well on ctDNA. Lung mets and peritoneal cancers aren't showing up very well on the blood tests, just so you know what we're missing when we do these tests. People criticize us all for doing this test, and they say, you don't know what to do with it. I think they're right. We don't know what to do with a positive test, but what we're doing at Georgetown and others is using this marker to start treating it, okay? So let's see if we can convert the Slytherins to negative. Let's see if we can flip their ctDNA so that they're negative, and maybe we need to rethink what drugs and how we use the drugs in this setting. I want to go back to our screening test. Think about this a second. So now I'm going to start screening for cancer with a blood test that is looking for DNA in the blood from cancers. This study is treating DNA in the blood, right, to try and make it go away. I think those two are going to collide. That you're going to go to your primary care doctor and there's going to be some blood test that says you've got cancer. I guess you do scans and scopes, try to find where the cancer is. But if this stuff really worked, you could say, screw it, we'll just treat you. We'll just make the cancer go away at the molecular level. So I'll be dead when this happens, so you young people will have to be in charge of this. But I think that's what's going to end up happening. It's a prediction. Don't bet on it, but it's a prediction. All right. We're going to go quickly because we've got to give time for questions about how do we deal with stage 4, no evidence of disease. This, too, is an audible that we call. Everybody know what I mean when I call an audible? We are in bingo country, aren't we? Yeah, okay. So, you know, you go up to the line and you call a play. And this is what we do in tumor boards every day. If somebody's got a lung met and a liver met, we say, okay, let's take the liver met out first. Let's give them a little chemo. Let's zap the lung met, and then we'll see what happens. We do it differently every time. There's no rules. There's no real parameters that we follow. Can we get the patient to no evidence of disease? And then we, the oncologists in the room, say, well, shouldn't we just give you a little chemo because it feels right? The answer basically says no. You're affecting progression-free survival, but you are not affecting overall survival. So either treat it like metastatic disease and give chronic maintenance therapy, or don't treat it at all is my strategy here. All right, the newest, coolest study that came out of ASCO is this one. The French are really the jet setters in our world, particularly the French surgeons. And they were the first ones that taught us about metastatectomy. And now they did this study where they took patients who had metastatic colon cancer only to liver, a very distinctive biology that we recognize over time. You had to be good health. You had to be squeaky clean. And I think I've got they're randomized between just continuing chemotherapy. They were unresectable because they had too many liver lesions versus doing a liver transplant. All right, so somebody had to die. In France, do they have motorcycle helmet laws? Do you have motorcycle helmet laws here? So that makes for the best liver donor pool right there, is that you just do away with motorcycle helmets and then there are plenty of livers around to give out. I'm actually not joking. There's a reason Steve Jobs got his liver in Tennessee, is that there are no motorcycle helmet laws in Tennessee. There's plenty of livers to go around. But anyway, so they randomized them. And so look at this. I want to show you one thing. Number of nodules there in the middle, all right? So a lot of these patients had more than 20 liver mets at the time this was going on. None of us would operate on, and we would say, this is crazy. We're not going to do liver transplant in that patient population. A lot of fall off through all of this. They'd had a lot of prior chemotherapy. So you can see it started up at the top with 157 patients. At the bottom, 36 and 38 actually end up getting randomized. But the reason I'm showing it to you is I think it worked. Right? So the people who ended up getting liver transplants could actually live a lot longer. There's a tail on this curve, too. that patients were hanging out with multiple metastatic lesions in the liver. So just quickly, what this really showed us is that it's feasible, it's doable. I now have a patient on the list. Our list is not popping up a liver within 65 days, and so we're nervously watching her cancer. I can't give her a lot of treatments because what if the liver shows up, right? She has to be kind of clean off of chemo before the liver shows. So I'm just nervously watching and hoping somebody has a bad day, gives us a liver. I'm going to close with just looking at stage 4 disease, and then we'll go to questions. I know you guys have got them. God, there's a lot of, oh God, I'm in trouble. So maybe I'll just keep talking. So let's look at this. It's not one cancer, all right? Now, people who trained in medicine in the room, how many hours did you spend learning about the microbiome? So I'm going to, first off, 1 hour of the 4 years of medical school. Who spent 1? How about 4? I'm going to go up to 4. Anybody spend a full day? More than that, more than a full day learning about the microbiome. So I think I had 2 classes on the microbiome. The current Georgetown agenda curriculum has 2 hours of lectures on microbiome where you memorize some names of bacteria, you get the question right, and you forget, right? And yet, if you were a plant doctor or nurse or caregiver, you would, if your plants are sick, you study the soil, right? You would naturally study the soil. Who believes in evolution? Let's go here. I know I'm in Cincinnati, so I know some will say no. All right. So you do? Okay, let's see how the votes go. Because one party doesn't, just to be sure, you know that. One party doesn't believe that evolution happened. So if you believe in evolution, we evolved to have critters living in our GI tracts. Okay, right? They're in there. I believe, I'm a fairly religious guy, that is where the soul resides. Okay? Think about it. You listen to your gut, don't you? You have a feeling in here. And they're living creatures inside of you. And why is the colon shaped that way? I actually think we know now that the right side microbiome is different than the left side. It's 2 pools. It's 2 different critters, two different groups of critters living in there talking to us. We know our immune system lives here. We know it because we can do stool transplants and make people respond, and we can give antibiotics and make people not respond to different therapies. So we know this soil is important to our health, and yet we don't even know how to measure it going forward. And so we know the right side is different than the left side. Rectum might even be different still, and we know it's probably something to do with microbiome, right? But we don't know how to measure it. We don't know how to influence it. The aisle at CVS clearly knows how to do this. There's an entire aisle of how to treat your microbiome, right? And probiotics, this and that. But I don't know how to do this. I am hopeful that bourbon is good for your microbiome. This is the only thing that's saving me, is that this might be a good thing for one's microbiome. So what are we going to test here? We know precision medicine is critical in all cancers. Colon cancer, no different. And you see there the different genes and targets that one needs to test in these patients. And as a result, you have a chessboard of drugs that are out there. The first column, those that don't have a precision medicine test. The EGFR used to be everybody got them. Now we're down to 15% of patients who are candidates for the EGFR therapies, 9% on the BRAF pathway. We now have G12C for us as well, and the rare tumors that are out there on the side, HER2, et cetera. It's remarkable how many people are not doing this testing. The US standard right now, what we're seeing on average is somewhere between 50 and 70%. I would challenge you that every breast cancer patient you have, you know their molecular tests. And so the question is, can you get to that 90%, 95% in colorectal cancer where you know all the molecular tests for them? Because it matters. There are different pathways, different drugs, different strategies, different chess games, depending on what their molecular markers are. And you can see how these play out here. I won't go through all the studies that support that. But my last slide is this. So how are you keeping track of this? So if you're like me, most of your genetic tests are on a PDF scanned somewhere in the back of your chart. It could be that you ordered the test and you know where it is because it's electronically dropping into the place where they always electronically drop, okay? But a lot of times, if you're a second opinion or not, it's page 37 of 110 outside record pages that somebody went whoop, 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 into the EMR. And you have no idea where it is, and it's really hard to read. And so how do you know you did the tests? Do you take the time to go back and look for it? Do you bring it forward to your HPI? I make it red because I'm stupid. I need to see that I did it. And I can do a call out to myself that I know that it's there in our charts. And we had a big discussion about EMRs and how do we, make this better for us. We know it's out there. We know the technology is out there. Why isn't it prompting me this instead of telling me, could I use less IV fluids? Because, by the way, the Baxter plant's still broken, right? Who's living that, by the way? Yeah, y'all got it, yeah. So this is the prompts I'm getting instead of, do you know your patient has a HER2 positive colon cancer, and you're making sure you're treating them, right? So we need to make our EMR grown up and prompting us not just to bill people, but to take better care of patients. And with that, I'll shut up and let you guys come at me. So thank you all very much.
So we can now open up for questions from the audience. Anything about colon cancer? You want to include GI cancers as well? Or anything on the GI word, we're happy to ask.
I would like to ask a question. I'm Alex Tardo from Christ Hospital. So my question is this. If you continue the parallel with breast world, right, we know that if somebody has HER2 overexpressed tumor, you want to give HER2 inhibitor, right? So the question here, now that we know that KRAS G12C, for example, right, produces in metastatic disease very good results, why don't we advance it and see if it's going to help in adjuvant settings, right? So what do you think about that?
I agree, and I think it's what we should be doing. So one of the problems I've pointed out is that we're not moving these drugs to earlier lines of therapy. Now, guidelines are fairly loose, so most of us, I would say, are probably using that when you get a G12C or something fun like that, using it maybe second line, because let's face it, FOLFIRI Bev in second line has a response rate of 15%, where these other drugs are much better response rates anyway. So we're using them earlier, but why aren't there studies in investing? It's smaller subgroups, right? So to do the studies to get approvals is harder. One of the things we're doing with the Colorectal Cancer Alliance is, again, taking a page from the breast cancer world. We're building out an I-SPY kind of platform where these drugs can come into these earlier slots so that we have more of a comfort zone. I mean, but let's also face it, we have pharmacy benefit managers, I love these people, who, when you try to order something out of line, you get a rejection, right? And you have to then do a peer-to-peer with a burned-out rheumatologist to defend your choice, right? I mean, you're laughing because it's true, right? I mean, and to defend your choice to give the drug out, they want you to give FOLFIRI first. And their hope is, of course, the patient will be dead before you need to use this drug. I'm serious. That's the sort of strategy, is to push it down the road. So we're disincentivized to bring the drugs to where we think it's the right thing. So I couldn't agree more with your comment. Thank you.
Yeah, two questions. One, Dr. McQuaid at MD Anderson in the melanoma space did a study and showed that pretty much all of the over-the-counter prebiotics actually ended up with a worse outcome with the immune therapy, which was interesting. The second question I had, which is probably more weird, but I saw a paper about vagal nerve stimulation and increase of immunotherapy effects on the intestinal system, and would be interested to see what your comments on that are.
Well, again, I don't know that we know how to control these critters inside of us, but that's the point of that, right? Is could we somehow alter their environment so that they're helping us more, that it's whatever healthy looks like. Yeah, I love the probiotic aisle, because to me it's like taking a beautiful rainforest and cutting it down and planting a bunch of pine trees and saying, I've got a rainforest again. No, you don't. You have, a Christmas tree farm. So it's, we don't understand what we're doing. But I think there were two papers in the most recent JCO, 2 JCOs ago, sorry. One was if you had an E. coli gene in your lung met, that your response rate was much higher to immunotherapy. So some sort of symbiotic, maybe it's a signal, maybe it's actually helping with the immune system recognition, I don't know. So that was an interesting paper. And then primary rectal cancers, MSS rectal cancers, chemo plus IO, 50% path CR rate. That's the highest path CR rate we've ever had outside of the MSI patient population. So it says something about localized tumors, to me, that are juxtaposed or haven't figured out how to exist without the microbiome next door to it. So if that microbiome is somehow there, or it hasn't figured out how to spread, then there's a different response. So the point being is our traditional drug development of taking signals from refractory disease and applying it to the adjuvant setting probably doesn't work. We need to think of it as a different setting.
Thank you, John, for a great and stimulating presentation as usual. What is the ideal way of using MRD? The ideal way of using MRD testing.
Of using it.
How you recommend it being
I do my test every day. No, no, all joking aside, I think it is very valuable information. But the counter argument is that why do you want to know bad news sooner? Right? So because you can't do anything about it. We're not treating the number outside of clinical trials. But for example, I have a patient who had stage 2 disease, young woman, rectus sigmoid, MRD positive. So instead of no treatment, because the standard with stage 2 can be no treatment, we started her with CAPE. When her test came back positive, we added OX. I still don't know if I'm right or not. And her MRD is flipped. So did I do that? Would the CAPE alone have done that? I don't know. But it made me change it's really according to that clinical trial, it made me modify my treatment. And if she's still MRD positive at 3 months, that's where I really don't know what I'm going to do. I mean, do you just extend? Is that the 1% that's going to flip with another 3 months? I doubt it, honestly. So I think we need to find a new therapy set of guidelines for those patients.
I think, there is a lot of confusion about how to use this MRD test. So let's say you did not have a baseline before surgery. I mean, you don't know whether the tumor
so there's tumor enriched. There is a lot of language around these. There's two kinds of tests. There's the just go get a blood test. That's a garden test, is that. And they're looking for genes that are in cancer, not necessarily the ones your cancer has. The counter argument is the Natera test, where it's tissue informed. So the tissue is sent, it's profiled, and then using some magical AI, they figure out 16 genes to monitor, and then follow those. So if you're following a specific gene of that patient's tumor. So a lot of our patients, there's no tumor to do the MRD testing on, so they can't have it. If you had a really good response and your baseline biopsy wasn't good enough, you can't do the tissue-informed one. So they're different tests, and they tell you slightly different things. And anyway, we can go on for an hour on just that subject, but you need to know what you're ordering and why.
Yeah, but the physicians really need a lot of guidance, at least how. So if you have the tumor existing and you did the MRD testing in the blood, and you did not catch the ctDNA, how do you expect you are going, if your tumor does not shed the ctDNA to start with?
Right.
How are you going to know? So there should be a systematic way of ordering the MRD. It's not fair to order it post-surgery and you don't know whether the test is good to start with or not.
That is the standard time to do your first look. But I understand what you're saying, is that different tumors, not all the tumors shed enough to pick it up. So I agree. Yeah.
John, I wanted to thank you publicly for the great help you were with a particular patient. Amy was 29 when she was diagnosed with metastatic colon cancer and had been through all the routine treatments, chemotherapy, radiation, surgery here, refractory to everything. Her CA level was 550, and this is when immunotherapy was new. There was reluctance locally to her have immunotherapy. You saw her, recommended that. She was on immunotherapy, and she's out now 8 years and got married this summer. So
there you go.
Can't thank you enough for that.
Good story. Well done.
But I did want to ask your opinion on theories on why the young people with colon cancer. There's a lab here at UC studied the microbiome. I think they've come across a particular bacteria associated with processed foods that may be the culprit. But just interested in the strong theories that are out there.
No one knows. Everybody's got a theory, and whether it's whatever was on the front page of the paper. Was it microplastics? Was it whatever ultra-processed food? The New York Post, right, had a headline yesterday, 2 days ago, that they were sure, that some reporter there was sure that they found what was the cause of it. And then all of the people who actually knew were like, that's made up. It's just not a real story. So we don't know. We don't know. But if there is any positive thing from this, is that it's money's going in. We are thinking differently about it and how to figure it out. Because, do you change screening or not? Can you figure out some other signal to figure out who's at risk? And what I'm hoping is that whatever we learn will actually not only affect young people with, prevent this from happening, but also lots of other diseases that are out there that I think are probably going to come out with the same story. That's my fingers crossed. But so we need to hurry up and figure it out. A lot of that 100 mil is going to figure this out. All right. You guys have thoughts and theories on young people with GI cancers?
So I think there are a lot of hypotheses going on, but then I think microbiome is one, and I think there might be more to the personalized medicine and things that might be different individually. I think, I've seen 21-year-old with metastatic colon cancer, and then we do all this NGS testing and P53 comes back. I mean, that's like, that's very common things. But I think a lot of these NGS we do, we still are not very sure of what's going on, and I think we need more studies and research done to understand these things.
Same thing. I think it's probably some interplay between the environment and the microbiome in many of these individuals, because so many of them, you do genetic testing, nothing comes out to suggest that they are predisposed. Many times, quite a number of them are the first cancer in the family. So it's really an area of certainly a lot of active research.
And by the way, ultra marathoners and big runners have the worst colons. They're just, if you biopsy them, they have dysplasia all over the place. They have, and we don't know whether it's some sort of trauma, like hypoxia or something like that, versus the protein junk they eat, because they have these big eating habits that go with being big runners and stuff. So we're not sure, but if you look at specifically that group of people, their colons are a mess. So, which means bourbon and bike riding. This is the two. It's the way to go. Anyway, you all have a great rest of your meeting. Thank you.
Thank you.